would you speak out rather than texting the message, because it won't be visible to me. And for this, the answer is hyperlipidemia. Why thiazides is not used for hyperlipidemia cases? Now, first of all, we'll see what thiazide is. Okay, thiazide is a diuretic. It decreases the volume of blood. Now, because it decreases the volume of the blood, it is also used as a first line for management of high blood pressure, that is hypertension, which is very clear to us. Then it is also used in case of congestive heart failure, because when the amount of fluid in the body decreases, the work that the heart has to do, it also decreases. So with lesser volume of blood, heart has to work less. So thiazide is also used in case of congestive heart failure because the heart is already in compromised state. Now, idiopathic hypercalciuria is a condition in which there is excess excretion of calcium. And with excess excretion of the calcium, sometimes these calcium, they combine together to form stones, leading to nephrocalcinosis. So whenever you give idiopathic hypercalciuria with nephrocalcinosis patient with thiazide like diuretics, what happens is that thiazide like diuretics, they enhance the absorption of calcium. With increased absorption of the calcium, there will be less of calcium excretion in the urine. Therefore, it can prevent nephrocalcinosis. Okay, our second question. Which diuretic can be considered appropriate for combining with ACE inhibitors? Abhishek Thakur, are you there? Abhishek Thakur? Nitesh Yadav?
Yes, sir.
Okay, which is the answer?
So option 1, spironolactone.
Why do you think it's spironolactone? Okay, the answer is hydrochlorthiazide. Now, generally ACE inhibitors, okay, they are contraindicated in hyperkalemic state. Means whenever the level of potassium in your body is very high, in such scenario, ACE inhibitor like drugs, which is another antihypertensive drug, should not be used. But when you look at these options, okay, if you look at your first option, which is a spironolactone, if you see a second option, which is Eplerenone, and if you see a fourth option, which is Amiloride, all of these three drugs belong to the same category, that is potassium sparing diuretics. So sometimes the question is put in such a way that all the rest of the option, their mechanism of action is same, except for the one. In a patient of head injuries with rapid increased intracranial tension without hematoma, the drug of choice for initial management would be Anil Thakur. Are you there?
Yes, sir.
So the answer is
Number 3.
very good. Why?
Sir, Because of mannitol.
Yeah, but why? Okay, anyways, it reduces intracranial pressure, but without hematoma. Means if there is a presence of hematoma, means what can happen is there can be loss of blood. In a situation in which there is already a loss of blood, then giving a diuretic can further decrease the amount of fluid in the body. So only if there is no loss of blood, or in case of if there is no hematoma only, then it is good that you start mannitol. And mannitol remains a drug of choice in case of head injuries with increased intracranial pressure. Thiazide diuretics causes all except Samatimulsina.
Yes, sir.
Answer please.
For increased calcium excretion.
Okay.
No.
Thiazide diuretic causes all except increased calcium excretion. So thiazide diuretic does not increase calcium excretion, but it enhances calcium reabsorption, and that is via the parathyroid hormone. Regarding furosemide, true statement is Subrashaw. Subrashaw, are you there? Deepika Subedi,
Yes, sir.
answer please.
Option number one.
Okay, acute pulmonary edema. Furosemide happens to be a drug of choice in case of pulmonary edema. One of the following diuretic does not require its presence in the tubular lumen for its pharmacological effects. Priyanka Rajouri,
Yes, sir.
would you like to say the answer?
Number 4.
Very good. Why? Why? Okay, if you see these three options, thiazide, loop diuretics, as well as carbonic and anhydrase drugs, all of these drugs needs to be secreted in the tubular lumen. The secretion is from the ion transporter, which is the same transporter that is required for secretion of uric acid in the urine. All these three drugs, thiazide or loop diuretics or carbonic anhydrase inhibitors, they compete with each other as well as they compete with uric acid. So these drugs, they happen to increase the uric acid level in your blood. However, the fourth option, which is aldosterone antagonist like spironolactone, Eplerenone, they are steroidal in nature. They are lipid soluble and they do not require any kind of transporter. On top of that, they bind to the receptor which is inside the cell. So because of its lipid soluble nature and because its binding site is inside the cell, it is one of the drug or the only drug which acts from the basolateral side and not from the luminal side. Intravenous furosemide is used for rapid control of symptoms in acute left ventricular failure. It provides quick relief of dyspnea by Prince Mahato. Are you there? Prince Mahato. Mega Swaraj. Mega Swaraj, are
Yes,
you
sir.
there? Would you like to
Yes, sir.
see the answer?
Yes, it causes the venodilation.
Which one?
So the third one.
Okay, causing venodilation. Would you like to put some explanation to it? Okay. Furosemide is a loop diuretic. Now, when you give a loop diuretics, definitely it produces diuresis. On top of that, furosemide is a highly efficacious diuretic. But when it comes to rapid relief of the symptoms, the main cause behind that rapid relief is because of venodilation. All of these drugs, which are loop diuretics, they contribute to vasodilation, because of which there is drainage of fluid from the lungs into the systemic circulation. Because of that drainage, there is more surface area available in the lung for gaseous exchange. So there is immediate relief of symptoms of pulmonary edema, which is a feature of acute left ventricular failure or right ventricular failure or cardiac failure. Both loop diuretics and thiazide can cause hypokalemia by Utsav Chapagai.
Three, sir.
Yes. Would you like to see the answer?
Increasing the availability of sodium in the distal tubular fluid to exchange it with interstitial potassium.
Very good. So the main action of most of the diuretics is prevent absorption of sodium from their respective sites. It is carbonic anhydrase inhibitors, they inhibit absorption of sodium from PCT. If it is loop diuretics, they inhibit the absorption of sodium from ascending limb of loop of Henle. If it is thiazide, they inhibit absorption of sodium from DCT. So all of them, they inhibit the absorption of sodium from their respective site, leading to increased availability of sodium in the distal tubular fluid, where the body will try to absorb as much sodium as possible. But that is only possible if it can be exchanged with potassium ion. So this can ultimately lead to low potassium level in the body, which can also lead to symptoms like muscle pain, muscle cramp, or sometimes even some life-threatening conditions, which can be like arrhythmias, which might require immediate hospitalization. So that is why these ions like sodium, potassium are most of the times sent immediately once the patient is hospitalized, no matter what the reason is. Indomethacin can antagonize the diuretic action of loop diuretics by Shweta Verma.
Yes. So first option by preventing prostaglandin mediated intrarenal hemodynamic actions.
Very good. By preventing synthesis of prostaglandin mediated intrarenal hemodynamic action. Because loop diuretics, they stimulate formation of prostaglandins, whereas indomethacin being an NSAID, they inhibit the synthesis of prostaglandins. Which of the following diuretic can result in metabolic acidosis? Suchikizu,
Sir, furosemide.
No, actually it is acetazolamide. But when you have, if acetazolamide is not in the option, you might have guessed it right. But furosemide do also have minor amount of carbonic anhydrase activity. Similarly, hydrochlorthiazide also have minor carbonic anhydrase inhibitor activity. But among the four options, the main which has maximum inhibiting action on carbonic anhydrase enzyme is acetazolamide. So there is loss of bicarbonate ion. So the urine will be alkaline, whereas body will be acidic. Long-term use of which diuretic agent can result in gynecomastia? Vanshdeep Sarma. Are you there? Sanish Hossain. Okay, very good. Spironolactone. Amiloride can cause hyperkalemia due to its action on Abhinav Jha. Ganesh Joshi.
Yes, sir.
Answer.
Sir, 2.
Okay. Electrogenic sodium channel. So amiloride differs from spironolactone in that Dilasha Karki. Dilasha, are you there?
Yes, sir.
Answer.
Sir, option number 3, it acts from the luminal membrane side of the distal tubular cells.
Very good. It acts from the luminal membrane side of the distal tubular tube. Now, although both amiloride and spironolactone, they are potassium sparing, these potassium sparing also have two categories. One is aldosterone antagonist and another one is direct acting. The aldosterone antagonists like spironolactone and eplerenone, they act from the basolateral side or from the blood side, whereas amiloride, triamterene, they act from the urine side or the luminal side. So with this, we finish our diuretics. Is there any confusion? If there is, then do let me know right now so that we can go back to that particular slide and talk about it. Is it no? So shall we stop the class? Thiazide and ototoxicity. Okay, thiazide and ototoxicity. Now, first of all, before we say thiazide and ototoxicity, generally it is because of a drug interaction. Hydrochlorthiazide is being taken by our parents. It is one of the first line for management of hypertension because it is a medium efficacy. We do not, if the patient is hospitalized, if it has pulmonary edema, if there is swelling on the feet, then you go for highly efficacious diuretics like furosemide. But if a patient is not hospitalized but is staying at home and has high blood pressure, then the first drug that is given is hydrochlorthiazide, AC inhibitors, or ARB-like drugs. So generally when these patients are taking those drugs, you do not find ototoxicity. Their hearing is still intact. Our parents can listen to us very nicely. But the term ototoxicity generally kicks in during two conditions. One condition is when the person overdose himself with thiazide, which is less likely. And second condition is when thiazide like drug and another drug which is an ototoxic drugs are taken together, like aminoglycosides. So thiazide like drugs, if combined with aminoglycoside like drugs or even loop diuretics, when combined with aminoglycoside like drugs, they can lead to ototoxicity. Now basically the reason behind that ototoxicity is that for the hearing to happen, there is requirement of the fluid inside the ear, and that fluid is produced by the transporters like sodium chloride symport and sodium potassium 2 chloride symporters, which is required for the secretion of endolymph, the fluid which is inside the ear for hearing purpose. So if that sodium chloride symport and sodium potassium 2 chloride transporters are inhibited, then that can lead to ototoxicity. But under therapeutic dose, that is generally not inhibited. Only at toxic dose or whenever you combine that drug with some other nephrotoxic, with another drugs like aminoglycoside, then that generally happens. Now we have why mannitol contraindicated in pulmonary edema. Now here what can happen is that, okay, free water clearance will come to that. Now first we'll talk about pulmonary edema with mannitol. Now first thing is we already have established drug for pulmonary edema which is highly efficacious. That is furosemide. Trying to manage pulmonary edema with another drug is another risk factors. Second thing is that mannitol is an osmotic diuretic. It has the capacity to absorb its water from the surroundings. And there is no clear-cut demarcation that mannitol does not enter the lung. If fluid can enter the lungs, then similarly mannitol can also. So if mannitol happens to enter inside the lung, then pulmonary edema can be exaggerated. So instead of relieving of the symptoms, pulmonary edema can exaggerate, which can be life-threatening. Now coming to the free water clearance. Now free water is the extra volume of water excreted in excess for that to dilute and excrete the waste metabolite. Now here free water this is the definition. Now free water is something, okay, that is generally absorbed from two sites. The reason I have not mentioned free water in the slide is because I don't find that much significant. It can be confusing, but in KD Tripartite they talk about free water, and also we have terms like positive free water and negative free water. Now when it comes to free water, means water that is absorbed irrespective of any movement of sodium channels. Here where Anish has written free water clearance is extra volume of water excreted in excess for that to dilute and excrete the waste metabolite. That is also there, but in simple understanding, if water is absorbed irrespective of any sodium ions, like in case of mannitol. When you give mannitol, the water is absorbed, but along with the water, there is no movement of the sodium ions. So that is free water. Water is free of all the solute or the sodium ions or potassium or calcium ions. Now, free water clearance. When those for free water to be absorbed, there are two sites. One is the PCT, proximal convoluted tubule, and the next one is descending limb of loop of Henle. These two sites are site for free water absorption. And if you see the video, let me show you one slide first. Here you can see the water being absorbed, okay? And here also you can see the water being absorbed. So this site is the site for free water absorption. But if you see over here, that this segment lies in the cortex and this segment lies in the medulla. So anything that will enhance more water to be absorbed, we say there is positive free water. And if there is anything that will inhibit this movement of water in this area, then we call it negative free water. So that is what free water clearance is. Anything, any other questions? Hyperkalemia and osmotic diuretic. Okay, now osmotic diuretic is mannitol. Mannitol, when it is filtered in the glomerulus, mannitol is filtered in the glomerulus, and from the glomerulus it will act both in the PCT, it will act on the loop of Henle, DCT and collecting tubule. Now when the water is being absorbed from this site, water instead of being absorbed from this coming out over here, it will enter, it will remain in the tubule itself. It cannot be absorbed. So when water remains, when the water is when the urine volume increases because of osmotic diuretic like mannitol, automatically the concentration of sodium potassium in your blood increases. So not only there is hyperkalemia, there can be hypernatremia also, because there is only free water loss. There is only increase in volume of urine, and that urine consists of water and less of sodium potassium. So your body will be losing water, but not ions. That's why you'll have hypernatremia, hyperkalemia. Any other questions?